Good afternoon, everyone. Good afternoon.
Good afternoon.
Whoa.
Good afternoon.
Am I not in Harlem? I'm a little confused. Good afternoon, everyone.
Good afternoon.
We're so used to being in Zoom land that folks are like, she spoke. So, welcome. My name is Deborah Levine. I am your Community Engagement Officer for the City University, the Graduate School of Public Health and Health Policy. Welcome on behalf of our Dean, Dr. Ayman El-Mohandes. This is now your home. Please feel free to come and participate and find this space as a safe space to have hard conversations. That's the goal for this space right here. So for those that are in Zoom land, we are at 55 West 125th Street in the village of Harlem. This is one of the few webinar conversations that we are actually having that is hybrid. So for those folks who are watching us, there are folks in the room, folks in Zoom land, and hopefully today in the next 90 minutes, we can begin to engage in a conversation that will allow us to really start delving into what it means to have access to medical cannabis and how do we best educate the community constituents around us. So this is the Cannabis Corner Webinar Series number 4, Therapeutic Applications of Cannabis. We are fortunate today to have a moderator that not only is a community resident, but is a shero in this community when it comes to advocacy, when it comes to education. She is a treating physician and also not only treats the body, but also helps with the mind and the spirit. And we are very fortunate to have Dr. Cheryl Smith join us this afternoon. Yes, I was talking about you. She's looking at me like, really? Yes. She has been a friend, a mentor, but most of all has really helped guide this conversation. And so we also have Dr. Duclas Charles and Dr. Maurice Hinson, who will be talking to us. I am not going to spend a lot of time here. What I really want to say to you is that thank you. Thank you for allowing and giving us the opportunity to have this conversation and for you all to be able to join us in this space. So without further ado, let me get to some of the administrative stuff so that we can get that out of the way so that we can move the conversation forward. Want to thank our partners. As you can see, we have the New York Cannabis Community Boards 9, 10, 11, 12, Canadiva. We've got the Black Health Connect. We've got CannaPharmD. We've got Cultivating Community Foundation, Mixie Blossom, but most of all, we have you. And so right there, that requires an applause because there's some courageousness to be able to step into the space. And thank you for our folks in Zoom land. You'll see that there is a QR code at the bottom of these slides, which will allow you to do a few things. It'll allow you to take the poll. And it will allow you to also put questions in so that we're able to moderate that. Could someone get the door? So you'll see using the QA feature, if for folks in Zoom land, if you don't see the toolbar, shake your mouse and the toolbar will come up. You can click the Q&A to put your questions in. And only the moderators will see the questions. And if we don't answer them today, we will attempt to send them out to you with answers when we send out the thank you email. Next slide. So here is our agenda. As you see, we're going to keep this really simple because we really want the conversation to flow. We'll move through the introductions, we'll do our discussion, and then we'll open it up for Q&A, and then we'll do some key takeaways. Agreed? Agreed. Yes. Okay. Next slide. And without further ado, here are our learning objectives. Also, please know that this is a webinar that is being recorded. It will be housed on our YouTube channel. And for those that have continuing education needs from the public health sector, you will be able to use this webinar to get your continuing education credits. The goal for us is hopefully by the end of the year, we'll be able to offer all continuing education credits for a variety of professions. That's the goal. Next slide. And so without further ado, I'm going to decrease so that our moderator will be able to increase in this conversation. And I just want to say again, thank you again.
So good afternoon or good start of, I don't know, is it Evelyn? Not Evelyn quite yet, but it's coming. So thank you to Deborah Levine, who's always amazing, has been amazing to our community for a very, very long time. But let's hop right into it. We aren't actually even going to do any introductions. They will sort of declare themselves as they speak in terms of what it is they do and where their hearts are, and we'll allow them to do that. We've also agreed that we're going to have a conversation this afternoon. So you do see that there are specific objectives that we have. However, we want to make sure that we also meet your individual objectives. So we'll have the conversation move accordingly, and I'll move it accordingly. So if you do have a question and it becomes more than a question, but a comment, I'll move that too. So I'll use moderator privileges very lightly, delicately, but nonetheless use them. So that said, I will first ask Dr. Charles to introduce himself by telling us what he does, and you have to give a fun fact. You have to, but you can only do it in 1 minute. You don't need it.
Yeah. You have that. All right, there we go. Can anybody hear me all right? Yeah? All right, well, good afternoon, everyone.
It's on.
It's on? Yeah, it's on. My name is Dr. Duclas Charles. I'm a pharmacist from Brooklyn, New York. I've been a pharmacist for about 10 years now. Howard University trained. I went to there for undergrad and for pharmacy school, and got my doctorate in pharmacy in 2014. And I've done a little bit of everything in pharmacy: community pharmacy, health system pharmacy management. Worked at a tech startup in the pharmacy space as well. And I've been in the medical cannabis space for about 5 years now. I am the founder of CannaPharmD, so we are an education and consulting company. So I love going around and speaking about cannabis, medical cannabis, educating on the endocannabinoid systems, pharmacokinetics and pharmacodynamics of cannabis products. I'm also the founder of Black Health Connect. We are one of the largest intergenerational, interdisciplinary networks of Black professionals within the healthcare ecosystem. So we build community in over 22 cities throughout the United States and in 3 countries internationally. And it's a pleasure to meet you all and to be a part of this conversation. Fun fact.
One of them were fun.
I love bringing people together. I think that's my fun fact. So, and that unfolds in many different ways, but this space and other spaces as well. Yeah.
Okay, Dr. Hinson.
Yes. So again, my name is Dr. Maurice Hinson. I'm a general internist by training, working both as a hospitalist at Jamaica Hospital Medical Center, as well as a primary care physician through Medirootz Medical Group. I got into the cannabis space 3 years ago, about 3 years ago. I was unhappy with my job. I was working as a hospitalist, and I began to feel as if I was not really doing what I was meant to do on this earth. I actually felt I was doing more to continue the exploitation of sick people than actually helping them. And I wanted to figure out a way to keep people out of the hospital rather than treat them in the hospital. And I was actually met with the opportunity at the time to work for this company that brought potential medical cannabis patients in front of providers, and we would certify them. I'd always been a staunch proponent for cannabis use. I've used it recreationally since I was in high school. You know, I can say that now because it's legal. You know, it helped me tremendously, especially during residency, where I was having difficulty sleeping. You know, residency at one point in time was a traumatic sort of, you know, work environment. I had seen a number of gruesome deaths, and I would carry that home and not be able to sleep. And it would get so bad that, or it had gotten so bad that I wasn't able to sleep. And finally, when I did sleep, I was in such deep sleep that I slept through my alarm and got to work late. In fact, the chiefs had to come bang on my door to get me up twice. So, you know, being the only Black male resident, you know, whether or not that had anything to do with it, I'm not certain. But anytime you're the only Black person in a space, there's a certain spotlight that gets shown on you. And, you know, I had to go through this whole gamut of tests to prove that I wasn't on drugs, that I had to see a doctor, I had to do a drug screen, I had to do a sleep study, I had to do all these things to prove that I wasn't doing anything illicit to compromise my job, and everything came back unremarkable, negative. And the only thing they gave me was Ambien. And I tried Ambien for 2 nights. It was the worst sleep. I had nightmares, and I woke up more tired than when I first went to sleep. And so the woman I was dating at the time, she had a plug, gave me their contact information. I went back to Old Faithful and haven't had a problem since. So what I recognize now is that I had a form of PTSD, you know, and that was one of the earlier eligible diagnoses for medical cannabis. And so I was self-medicating, but lo and behold, now is an eligible diagnosis. And so knowing what it did for me, I said, well, okay, I have this job opportunity now where I can help other people who may have similar issues or some other ones. And I got into the space, but, you know, we weren't educated in med school on the endocannabinoid system. And, you know, I knew I wanted to be well-versed in it. I took the state's or the city's course, which is very basic. But then, you know, as a former researcher, I had done academic basic sciences research for 3 years prior to med school. And so I went back to the actual primary studies and began looking at some of the research that has been done already just to really get a hang about cannabis and the endocannabinoid system so that I can have an intelligent conversation with my patients so that they were well informed. And I did that for 1.5 years, and it was actually very lucrative because it was a cash-only business. I actually made more doing that than I did in the hospital. And so now I've broadened Medirootz Medical Group to not only include medical cannabis certification, but also full spectrum primary care practice, where we incorporate that as part of our entire holistic integrative model. That's what I do now.
So can I ask a question, because you are a pharmacist? So some of the effects initially where he was knocked out and the chief resident had to come find you, which was not that was. So can you talk about some of the potential side effects, individual potential side effects?
I want to be careful about even using the term side effects, right? Just medicinal cannabis or cannabis use medicinally could be used for different things, right? There are patients that may seek medical cannabis for assisting with sleep, right? But if you're up during the daytime and you don't want to feel sleepy, you might call sleep a side effect, right? So it just that's why I say I want to be useful about the term. There are patients that come in for things regarding anxiety. I think a lot of the times you see things associated with pain as well. All of the effects of cannabis are going to be they're going to be dose dependent. The amount that you take or how much you take is going to increase or affect what effects you notice or see or sense. But that what also is factored into that is your endocannabinoid system is unique. So how everybody reacts to cannabis is going to be different as well. Actually, I'm happy we do have the slides because I have a visual picture of that. That would help. But what I will say is, for in terms of what some people may, well, not I also would call a negative side effect. So one, the euphoric effect that happens with cannabis that some people seek intentionally. Technically, that's the one thing I will call a side effect of cannabis use, right? If you take too much, then eventually you're going to feel that euphoric effect. Medicinal use is about microdosing. So getting the dose that is large enough for you to feel the symptom relief that you're looking for, but still small enough where it's below your tolerance level, where you won't feel effects like euphoria, right? Or if you take too much cannabis, and this is past the point of feeling euphoric, some people will start to feel racing thoughts, paranoia, things of that nature, right? The way I like to break it down to patients is a lot of us are familiar with consuming alcohol. We've been socialized around it, even if you don't choose not to consume alcohol. But when you start to feel dizzy or nauseous, right, it's your body telling you this is too much. So I always tell patients that's the same thing, right? You start to feel anxious, things of that nature, that means you've over-consumed to an extent, right? And understanding how those doses affect you will also help you better manage your own care or your own therapy. That's what I love about the New York's medicinal program is that you have access to health professionals at a medical dispensary that can go over these things, right? When we talk about microdosing. Priya, there's a one with like a cup on it. But you get educated on that at the medical dispensary. So my main job when people were coming to the dispensary is one, understand what conditions they're using the products for, seeing if there are products that they can utilize that will help with those conditions, but also walking them through the different dosage forms, the routes of administration, and the best way to start off their process in terms of figuring out what dose works for them so that they can avoid effects that they may not want to see or side effects. Let me see.
I think it's coming up.
Maybe I
That
didn't
one.
put it. No, not
No,
that
not
one.
that one.
Yeah, it's like a cup. There's one with like an actual cup.
No, I didn't see
So
it.
I didn't put it in there.
Sorry.
The reference I wanted to make, and I didn't put it in the slides, is everybody's endocannabinoid system is like this picture right here, right? And Dr. Hinson, I think, wanted to talk about endocannabinoid system deficiency. I'll let you. I know you're working on a project with that, so I want you to go over that. But let's say this line right here on the picture, you can see on the very top. Let's say that is your normal or your your tolerance level, right? But this right here where the water is your normal level of your endocannabinoid system's activity. This level is going to be different for every single person, right?
Tell me what an endocannabinoid system, what is
The
endocannabinoid? 'Cause
endocannabinoid
they don't,
system. Oh,
they may not.
because I know we
quite-
went over this in another webinar. That's why.
So can,
No?
they did, but not, just give us a one-liner, just in case they weren't at the other
Okay.
webinar.
Understood.
Raise your hand if you understand what it is. Then we don't have to go over it. Only one person, two people.
Oh, okay.
I'll figure it out.
The
I
endocannabinoid
keep some
system.
startled faces.
Oh, yeah. So the endocannabinoid system is a naturally occurring system within the body that helps you maintain balance, or we call in healthcare homeostasis, right? So your body's goal is to always be in balance and to be in homeostasis. The human body is an amazing machine that works really, really well, but and at times, it could be off, right? But the way that it works is that the endocannabinoid system is monitoring all your different systems and functions throughout the body. And when it notices that something isn't working effectively, it releases chemicals, neurotransmitters that we call cannabinoids, but these are called endo because they're from within, right? That act as chemical signals that then, when received by cannabinoid receptors found all throughout the body, tell that system within the body to turn on or turn off whatever function needs to be adjusted, right? So that is how our bodies manage pain, sleep, appetite, things of that nature. As we get older or due to a deficiency in that system, right? We start to see that our body's normal response of regulating ourselves can then become less effective, right? So for example, arthritis, chronic inflammation. As we get older, a lot of us start to have arthritis, right? But normally when we're younger, our bodies manage that inflammation on its own. Inflammation is not a negative thing. It's the way our bodies fight infections, right? Bring blood to a certain area. But if it's chronic or lasts too long, it can then start to have a negative impact. So normally the endocannabinoid system would turn off that inflammation response. So it could be a normal length or a healthy length of a response. But if somebody has issues in that system, they may see chronic inflammation, right? That's an example.
So that's possibly the reason that cannabis works potentially for arthritis.
Well, so yeah, potentially people lean towards cannabis for arthritis because of things of that nature, right? But that's the endocannabinoid system, and the cannabis plant produces over 150 chemicals that look similar to the cannabinoids that we produce naturally. So in turn, they can interface with those receptors that we already have to help bring our bodies back into balance or homeostasis whenever issues occur. And that's why people are able to use cannabis as a medicine, right? Or medicinally to help with those symptoms. So that's
Can I just follow up also as it relates to making the distinction between medical and recreational use of cannabis? I think you touched on it a little bit in terms of making a clear distinction, because not all use is recreational, which is what most people think.
Mm-hmm. Well, I mean, I think it's more of a sort of legal distinction, right? So medical cannabis, you have to go to a medical provider to be certified, to be recommended right now. Adult use is free and open to anyone. But you know, when you really think about it, a lot of people do adult use and are self-medicating. Mm-hmm. So it's for medicinal purposes. So I don't really make the distinction in that regard. It's just, to me, it's more of a legal distinction.
Okay.
No, yeah, totally aligned with that. It's their personal use is what the term I like to use instead of recreational, right? You making a personal choice to utilize cannabis instead of categorizing it only as for fun. Because as Dr. Hinson stated, most cannabis use is inherently medicinal. Sleep. Whenever I utilize cannabis, I have a good time when I utilize it, but I also get great sleep that night, or I feel better, I feel less stressed. Stress, anxiety, same thing. People go to physicians to get prescriptions for that, but then they might be using it what they think recreationally or making a personal decision to use it, and it's inherently medicinal. The products that you get at an adult use dispensary and medicinal dispensary can also be the same exact products. It's just the understanding of when medicinal dispensaries, you have a health professional that can guide you through the process, or you might see products that are much smaller doses because medical use is inherently about, again, micro dosing, whereas an adult use dispensary might sell products that start at a much higher dose, right? A micro dose is like 2.5 to 5 milligrams. So at most medical dispensaries, most of the products start at like 5 milligrams, right? But if you go to an adult use dispensary, maybe not New York, because I think New York, building off the back of already a medicinal regulated program, they have some more medicinally dosed products. But I know I've gone to other dispensaries where the smallest dose I could find is 10 milligrams, right? So, or 15 milligrams, which for certain patients might be too much and cause that euphoric effect. But yeah, the difference, as Dr. Hinson stated, is more so the environment that you might be in, the guidance that you may get, but the product is exactly the same. It's just under the education around how to use it with intention.
What about depression? I mean, so have you utilized it at all for depression? As it relates to depression, has that occurred?
Yeah, I think, initially when I got into the space, there were only a certain number of eligible diagnoses. Anxiety, depression was considered other, but most people who came to me came for stress, anxiety, depression, chronic pain. I would say those were the top diagnoses. But now they've expanded it so that, it's at the provider's discretion, at least in the state of New York. So that sort of opens up the array of potential pathologies that we could recommend cannabis for, which I'm a staunch proponent of, because it's not limited to just those particular diagnoses that they had originally. In fact, I'm part of my research is on looking at its use in cardiovascular disease. Whereas I know you all recently saw the articles that said that, you know, cannabis use was associated with increased adverse cardiac events. Yes and no, you know, the data is out there, and yes, the numbers don't lie, but they can be misleading, right? Anything can be spun to say the story that you want. And what I gathered from that particular study was that smoking cannabis increase your risk for cardiac events. But, you know, as we know, smoking anything increases cardiac risk, and which is independent of the cannabis use. And so what I like to look at is, well, how can we use this plant, or what variation of this plant can we use for these different pathologies, right? Because we have over 700, 800 known strains of cannabis. There's a myriad of cultivation methods, extraction methods, consumption methods. And so to conflate cannabis use as if it's one type, I think it is an injustice to the versatility of this plant and limits its potential therapeutic benefits. What we need to do is get into researching, well, how does this particular strain impact the person who's suffering from X, Y, and Z, right? And that's going to take a long time to do, because like I said, there's so many different potential options. But, you know, looking at what smoking does versus what doing it as a tincture does is apples and oranges. They have completely different pharmacokinetic and pharmacodynamic profiles, and so you cannot treat them as the same. All right, so yes, I would agree that, you know, in the case that I gave with the cardiac disease, smoking it increases your risk. But I would argue that the consumption of raw cannabis does the exact opposite. And this is not my opinion. This has been scientifically proven that it reduces the metabolic pathologies seen in diet-induced obesity. They've done this study in rats. It's a 2020 study that we can pull up later, but it was a 2020 study that showed this definitively. All right, it achieved statistical significance. They were able to reduce body weight. They were able to reduce cholesterol levels just by the consumption of the native form of THC. So we talked about this euphoric effect. Well, that euphoric effect occurs because the native form of THC, which is THCA, so acid, becomes decarboxylated, and then is now able to bind to its CB1 receptor, which gives you this euphoric effect, this psychotropic effect. If you don't consume the decarboxylated form, or in other words, if you don't heat it, because that's how you decarboxylate THCA. If you consume the raw form, the unheated form, that THCA does not bind to CB1. It binds to other receptors. These other receptors are part of the inflammatory pathway, the fat production pathway, and a bunch of other different pathways that have nothing to do with the psychotropic effect. In fact, THCA is not a psychotropic. I don't want to say at all, but it's minimally at best. Okay, so this is why I'm saying we have to start stratifying the different usages, consumption methods, extraction methods, cultivation methods, and strains before we make these overly conflated conclusions.
Okay. I know that there's been several things out there as it relates to long COVID. I mean, obviously we're at a stage now where long COVID is increasingly, we're seeing more and more patients with long COVID coming in with symptoms as it relates to that. And there's some data. Can you tell us about any data that you're aware of as it relates to cannabis being therapeutic for long COVID?
Yeah. Well, I'll start off by saying that the earlier studies that showed that came out immediately post-COVID and cannabis use, they found that those who consumed cannabis had significantly better outcomes with COVID infection. And partly because the same receptor that COVID binds to, that ACE receptor, cannabis inhibited. All right, so it was a direct inhibition of the receptor that the virus needed to attack the cell. All right, so that was first. So, and we,
So I'm gonna push you on that one and say, what's the study that showed that? Because I know that probably what will happen is, because we do have a lot of clinicians or a lot of scientists that may be specifically in the audience, not necessarily here, but in the clinical, in the digital audience. Can you remember what that particular study
Yeah,
was?
what
So
I'll
they
do
can
is-
follow up?
yeah, what I'll do is I'll include the citations.
Okay, great.
And hopefully we can give those out, because there are a few studies that I put here. I didn't put that particular study.
Okay,
But there were two actually that I saw where they showed significantly reduced morbidity and mortality
okay.
post-COVID with those who reported cannabis use. Now, with respect to this idea of long COVID, so anytime you get a viral infection, you have some sort of remnant of that infection, whether minimally or resulting in, say, fibrosis, which is probably the worst thing that can happen to any organ system. All right. So if you consider something like COPD and chronic smokers, this can lead to fibrosing of the lung. And so anytime that you have an irritant, which is introduced to the lung, or a viral infection, it may predispose you to having a worse outcome or a more severe infection, or whatever the case may be. What we're seeing with long COVID, quote unquote, long COVID, is something very similar to that, where you still have this persistence of symptoms, a cough, shortness of breath. And I would imagine, and I don't know this for certain, I haven't seen the data, but I would imagine what's going on is this sort of progression of chronic inflammation, like what Dr. Charles mentioned earlier. Chronic inflammation we're finding is essentially the root of virtually all disease, whether we're talking about obesity, high blood pressure, high cholesterol, heart disease, liver disease, dementia, anxiety, cancer. These are all chronic inflammatory disorders. And so, you know, with COVID gave us this virus that now is going to have sort of a long-term consequences, because it continues to come back and be introduced into the sort of epidemiologic landscape. All right. And so I do see cannabis playing a role in helping to suppress the inflammatory component of this disorder. But that's across the board. Again, and it depends on how you consume it, once again. And now the study that I mentioned earlier, these are people who reported smoking cannabis. All right, so even though smoking, as we mentioned earlier, gives you adverse outcomes, even those that smoke cannabis still showed reduced morbidity and mortality post-COVID infection. All right, so there is something to it. Whatever sort of combination of flavonoids and terpenes and cannabinoids that you find present in cannabis, that helps to reduce the amount of inflammation that we find in these viral infections.
I know we discussed, or Dr. Hinson discussed the various methods by which cannabis can be utilized. Can you tell us a little bit more? Because obviously, most things that we hear about is someone smoking or you're walking. There's not one street in New York, that you can walk down that you are not, you're not smelling cannabis.
Yeah.
Like not one. Or if there's one, please let me know where it is, because I have not been there.
Are we allowed to make this interactive?
Yes.
All right. So, what are the different ways to consume cannabis? Anybody can answer. Brownie. So,
edible.
Consumption.
Yeah, edible.
What else?
Topical.
Topical. All right. Somebody said smoking, so inhalation. What else? Tinctures, so sublingual, right? And then dry herb consumption, which is also inhalation, right? So those are the main ones. So
Teas.
teas, that's that consumption as well, right? So perfect. There we go. So these are like the four main ways I would talk about consuming cannabis. You have inhalation, sublingual administration, consumption, and then topical use, right? So inhalation, that's what we talked about, people call smoking, right? Smoking is honestly a fairly new way to consume cannabis. Cannabis has been used as a medicine for over 5,000 years. And when they look at like ancient use of cannabis, it was more so consumption, like milled into a porridge or made into teas, right? Smoking is something they found in like the last 1,000 years from anthropologists excuse my,
Panther.
yeah, from historically, right? But smoking, right? Burning it. Then Daniel spoke to dry herb vaporization, right? So vaporization is a process. Smoking happens at a couple thousand degrees. You're burning your actual plant matter, your flower. I would say a bit unhealthier in my opinion. You're breathing in, you can be breathing in carcinogens, carbon monoxide, ash. If you're using a lighter, the butane from the lighter, right? Whereas dry herb vaporization, you're heating up the plant matter, right? And all of the chemicals in cannabis are essentially a liquid. If anybody's touched raw cannabis before, it's sticky, right? So it evaporates those chemicals and you could breathe them in, right? Because you're breathing it in, just like the way your lungs deliver oxygen to the blood, the medication or the active ingredients get pulled into the bloodstream almost immediately. So you feel the effects much quicker, right? So most people, they might start to feel something in the first 60 to 90 seconds, but it honestly takes about 15 minutes before you feel the full effect. And then you know to take another dose. So for anybody who's ever tried cannabis before, had an experience, you took an inhalation, you're like, oh, I don't feel anything. And you took another one, you're like, oh, I still don't feel anything. Then you took a third one, you're like, oh my God, what's happening? But it wasn't the third one that you consumed, it was the first one finally starting to take an effect. So that's why even as a patient, if you're going to utilize inhalation, you want to take one dose, wait about 10, 15 minutes, especially if you're new to cannabis, before you take another one. And then after that 15-minute peak onset period, it stays in the body for about 1 to 2 hours or 2 to 3 hours, depending on the person. Again, everybody reacts to cannabis differently. Once you build up a tolerance, that duration of action is going to shift as well. Then we have the oils that somebody pointed out, right? So under the tongue, sublingual, or in the cheek. So a few dispensaries in the city make sprays as well. You ever look at the skin inside your mouth? It's fairly thin. You can see capillaries, right? So chemicals can get absorbed through that thinner skin. So I would always tell patients, hold it under your tongue for about 60 and 90 seconds. There are also medications that you get at a regular pharmacy, like Suboxone comes in sublingual strips. Zofran or Danzatron, which is like for nausea, comes sublingually as well. So when somebody can't swallow something, if you're thinking about a condition where you would use a sublingual product for, right, under the tongue, you hold it there for 60, 90 seconds, then it gets absorbed. These take about 15 to 30 minutes to kick in, and then these stay in the body a little bit longer. So 4 to 6 hours, depending on the person. So it takes a little bit longer than inhalation, but lasts much longer. And when we talk about dosing, right, which there are people working on projects on how to standardize inhalation dosing, but inhaling is going to be different for everybody. Whereas if you're using a tincture, you know you're taking 5 milligrams under your tongue, and you know that's accurate, and it's easier to dose with tinctures at times, and then it lasts a little bit longer for something that's a bit more chronic or less acute. Then you have consumption, which I think a lot of people either know inhalation or consumption, right? It's either I've smoked something or I've had a brownie before, right? But consumption, ingesting it. So you have to swallow it. Your stomach breaks it down, right? Then your liver has to process it, which impacts everybody's liver functions are different. So that end result is also going to be different for people. But you hear how it's 3 steps before it even makes it to the bloodstream. That's why consumption takes much longer. So a lot of people take a bite of a brownie and like, oh, I don't feel anything. Then they eat the entire brownie. And then an hour later, which is how long it typically takes to kick in, they wish they never tried it at all, right? So but yeah, it takes about 1 hour to 2 hours for that to kick in. And this is like typically what I would recommend to patients with more chronic issues, chronic inflammation, because it lasts much longer in the body, 6 to 8 hours, 8 to 10 hours, depending on the person. And then you have topical products as well. So there balms that are available that are going to have a more localized effect. Some people state that they use them for things like psoriasis. We talk about these are all, again, skin conditions, but it's chronic inflammation, right? And they can use things directly or topically or in a certain area if they want to avoid systemic absorption. There's even suppositories that you can find, right? Intravaginal or rectal suppositories. So different ways to consume cannabis. There are different ways to consume cannabis without having to think about the smell that unfortunately I think has a negative stigma associated with it as well. And I think that's where people are also trying to find other routes of administration. Even from, I think smoking or inhalation is going to be something that we don't really see, to be honest, in the next 10 years, where people are going to shift to different ways of consuming, even for personal use. Where what was deemed be more acceptable per se, right? And also from a medicinal standpoint can potentially be a bit more accurate in terms of dosing. So those are like the different routes of administration.
That's great.
Yeah.
Sounds like what you're saying is that topical cannabis is really only used for dermatological.
No, some people use it for pain. It could be like a localized effect, so
Like you use it for
soreness.
skeletal muscular?
I think some people will try, right? Dr. Hinson and I had a conversation, like it was like a year or two ago. We're talking about like patches, things of that nature. It's only going to be absorbed but so much, right? So in my opinion, systemic absorption is always going to be your best bet. But some people in the beginning, they're afraid of even consuming it. So they want to apply it to an area that's sore, and they do feel a reduction in pain in that area, right? Some patients think they use cannabis for like nerve pain, and sometimes they'll apply like a CBD balm or a 1-to-1 balm. There's different ratios to that direct area to get some pain relief. Whereas some people, if they are more comfortable, they can consume a capsule or a tablet and then not have to worry about pain for a couple of hours. So it's really going to be dependent on the person, on what route they want to use. But topical can be for pain relief. It could be for dermatological things, inflammation. There's different ways.
And that also depends on the formulation as well. So the issue with a topical application of cannabis is that the cannabinoids are quite large and don't always permeate the lipid bilayer. However, there are like nano-wise formulations where they're saying that increases absorption, things of that nature. And then you also have to remember, there's a psychogenic component to it also. You know, if you apply it to your elbow because you think it's gonna provide you relief, and you believe that it's gonna provides relief. So we also have to incorporate that, and that's also one of the other elements that I appreciate about cannabis is that it brings in more of the spiritual nature back into medicine. You know, like I think this is one element that we completely disregarded when we talk about medicine and science. You know, medicine today is purely scientific, which I understand because at one point it was purely spiritual. They thought disease was a matter of possession by evil spirits. And then we had this scientific revolution, but now it's purely scientific. We need to get back someplace in the middle. And I think cannabis at least allows us to introduce that conversation back into the medical space. But, you know, that's where belief and faith come in. So if you think a medicine is going to work, it's likely going to work, you know.
So I think just to
For Dr. Charles, could you say more about the suppositories? And I'm interested in women's health, and I know that in conventional medicine, Valium suppositories are used in pelvic floor physical therapy. Can you say more about cannabis suppositories or?
Definitely.
And
I think in New York, I've seen some products that are, everybody familiar with ratios of cannabis? Because I keep using that term. So at medical dispensaries, you'll find things in different ratios. So 20-to-1, 1-to-1, or 1-to-20, and then you'll find numbers in between. On the East Coast, the first number is typically THC, second number is CBD. On the West Coast, it's flipped, but it's the ratio of one component to another. And typically a lot of products are THC and CBD heavy right now because those are the cannabinoids that most people understand in the industry, but you can find more niche or unique products that have the different, because again, there's over 150 different chemicals in the plant that all have unique effects. You can find things that have three numbers in the ratio, like a 1 to 5 to 10. But to go back to your original question, I've seen products where it's high in THC at 20-to-1, or equal THC CBD a 1-to-1, or a 1-to-20 where it's high in CBD. I've seen suppositories across those three ratios. And different uses. There is use for sexual health, right? Or wellness that patients talk about. And you can find like CBD products online marketed towards that, but also for pain management as well. A uterine pain, people who have really bad menstrual cramps or periods like that. Some people use suppositories for that, or they might use a topical product over their abdominal area. Pain fibroid pain as well. We talk about women's health, but also rectally, you see people utilize a product as well for pain too. So there are different reasons. But for what I've seen patients come in for more so for the pain side. So that's what I've seen. Well, those are more mucous membranes, so absorptions are much easier there. Those are where if it was like a high THC product, you'll feel pain relief, but you may also feel extremely euphoric because it's getting all absorbed, depending on the dose that it is, right? For CBD, there's also like it's a lot much easier absorption, but also again localized, closer to a localized effect if it's a lot of pain in that area specifically. But you're still going to get systemic absorption just because it is getting absorbed and then going into the bloodstream as well. Yeah, no problem.
Dr. Hinson, can I just ask a question about, we've been talking about the various modes of using cannabis. Can you just give us a sense of how you determine what dosage should be used? In terms of, do you just let the patients decide in terms of what they should start with?
Yeah. Well, that's the challenge. I mean, there's really no standardization, but we always say,
Right.
you know, start low and go slow, right? So you start at the lowest dose that you can get your hands on, and then up to the point where you actually feel the therapeutic benefit. Now, dosing is one thing, right? But then, you know, what formulation is most appropriate for you, right? And I think a lot of things go into determining that. So, for example, if someone came to me and they have a history of coronary disease and they had 2 heart attacks in the past, I'm not going to recommend that they consume cannabis by way of inhalation, right? Because we haven't, at least at the moment, achieved a level of understanding where we know the appropriate dosing for smoking where it won't increase your sympathetic drive. So just so everyone's clear what that means. So your sympathetic drive is responsible for your fight or flight response, all right? So it increases your heart rate, increases your blood pressure, increases your cortisol level, which are all things you don't want if you already have heart disease, okay? What we find is that delta-9 THC, so the decarboxylated form, tends to increase your sympathetic tone. So it's going to increase your heart rate, increase your blood pressure, increase your cortisol levels. That we don't want. So again, if someone comes to me with that heart disease history, I'm not going to recommend that they use a inhaled form. But again, raw cannabis, being the native form of THC, THCA, I find to be beneficial for that particular patient, because we found that the consumption of raw cannabis tends to decrease blood pressure, decrease blood sugar levels, decreases cholesterol levels, and therefore it decreases cardiac risk. All right, so it really depends on that particular patient. But again, we haven't really scratched the surface in terms of standardizing doses, administration methods, strains. I can't even. I'm not comfortable telling you, okay, go out and get Gorilla Glue because you have this. Like we're not there yet, you know. I do think that there are certain people who do, and this is where I think cannabis can really assist, because the culture knows, the street knows, that, you know, the people who've been hustling underground for the last several decades, they know the strains. You know, a lot of what I know about cannabis, I get from, you know, some of the guys I grew up with playing ball that sold weed when I went to college, you know. So now I think this offers the opportunity to marry the culture with the sciences. And I think, and once we begin to do that, I think we'll really begin to understand the full potential of this plant.
Can you both, based on just what you're saying, can you discuss the research part of this? Because as you both understand, I mean, dollars, especially in our community, the medical community is what I'm referring to. There is significant amount of money within research.
Yeah.
So can you discuss the implications for this, and having people of color come into this space? Where is that right now? Where are you in that space? And just really educate the people as it relates to it, because there are funds out there.
Yeah, there's certainly money. The question is how to get to it. How do we get to the money? And that's always been a challenge with people of color, people of underrepresented backgrounds, whether it's because we either don't participate in research or we're just not, you know, granted those funds, you know, somewhere along the way that, you know, we kind of missed the boat. But where I see,
I don't know if it's we missed the boat. or
We-
we are
we-
not on the boat?
We entirely, not us, not us. I mean, we as a medical community.
Right,
You know,
correct. I agree.
we as a medical community, I mean, because we're definitely out there and pushing to be involved in research, those who are providers. But for one, we don't have enough providers as is. So even if, say, all of us engaged in research, it's still not really going to tip the boat because there's not enough of us. But I do see research really getting into standardizing doses, getting into understanding the network effect of this plant, because it's not, I'm not a big proponent of isolates. So just taking CBD or just taking THC, I believe in whole plant medicine. So the full spectrum element, because it's the combination of all the compounds within the plant that affords us its greatest therapeutic benefit. And so understanding how that network impacts the body is a challenge in itself. And so we have a long way to go. And I think we can do it in baby steps where we look at certain strains or certain, I don't even want to go by strains, where we look at certain cannabinoid, terpene, and flavonoid profiles and be able to associate them with certain therapeutic effects. All right, that's another area of research. But then, just from an access standpoint also, so we discussed earlier, we're not actually being involved as patients. Okay, so I've been in this space, like as I said, for the past 3 years, and the overwhelming majority of people who I've certified are white people. And I'm very intentional about going into our communities and certifying our people, but it's just not enough being done to market to our communities. And then the affordability of the products themselves, right? If we are really going to regard cannabis as a medicine, then it should be subsidized by the insurances. And at the moment, that's just not the case. I do know the New York Assembly Committee put out a bill last year for state insurances to subsidize it. So it looks like steps are being taken, but this is a health equity issue. I can only really speak for the health equity component, but we can't really start to talk about equity when the products are unaffordable by the people who would get benefit the most. So it's so many different layers. And in terms of research, we can do research which shows the cost effectiveness of including this as part of our therapeutic regimen.
So I'm going to just push a little bit and have you explain this a little bit more when you're saying that it's cost affordability for the people that need it most. Our people have been using it for a long time. And I'm assuming, just so you can clarify your comments, that you mean at the doses and the purity that you think is needed, because it's not just the person that's on the street.
Right. Well, what I would say, I can't speak to the purity aspect, because I know a lot of people who hustled it that grow it themselves organically. So, and I don't know where these stores are getting it from and what they're putting on it. So I can't speak to the purity from street dealers. That's arguable. What I can say is that we have to get to a certain point where we can start having the conversation in medical spaces where it's not stigmatized, that the provider is not already laying in their bias, because if it is a therapeutic option, we have to regard it just like we do any other medication. So I think part of that is a culture change in how we discuss it as well as providers.
Yeah, I want to speak to the last point you just made and then go back to the earlier comment. The culture change, right? I think that's why the education piece is extremely important. Having more people who are willing to talk about it, educate on it, and even patients educating their providers as well. So a lot of people used to come into the medical dispensary like, hey, how do I get a card? And the first thing we'd always say, and like my old manager educated me on this, and I stuck with it, was go ask your primary care provider first, right? There are ways, there's via telemedicine, seeing physicians like Dr. Hinson, right, that specifically provide that as a service is great. But when you go to your doctor's office and say, hey, I want to get a medical card, if they're not already in the program, but you're the fifth person or sixth person to ask. Now they're going to be like, oh, maybe I should go do the education and educate myself and get into the program, right? I think a lot of all of this is, again, big with health providers, with folks in our community. The education piece is the main issue. Same thing with people utilizing it medicinally as patients, especially within underrepresented communities. We have been traumatized like twofold, right? We got the same propaganda everybody else got with the Reefer Madness documentary and all the negative things that they've stated, right? And then on top of that, if you come from a Black and brown community, you see how the war on drugs has affected your community, your family. So there are a lot of us who have the capital to get into the cannabis space that aren't getting into it because they still see it as a negative thing, or that are going through really bad health issues and they're trying every other medication, dealing with the side effects of those medications, doing multiple surgeries, but because it was drilled into their minds that cannabis was bad, they don't want to try it and utilize it, right? And once you have the opportunity to educate that physician or that patient or the person that could be an investor or can invest in a research project or be a part of it, once that stigma is taken away, it opens them up to utilizing these products or getting involved. So like that, I just wanted to bring that back to your earlier statement and say that's why education is so important. And like all of us can do it as patients, as public health professionals, or as providers, because we need it in both directions. My favorite conversations are like the older patient that comes in the dispensary, like my physician told me to take this, but I'm not buying anything. I just want to talk to you. And then once they have a conversation, they're picking like 5 things off of the menu and they're going to try what they need for their condition, right? But really having the conversation just shifts that thought process altogether. Then to, sorry, I forgot the other thing you were talking about, but there was something you were saying that I really wanted to talk about.
Well,
too.
I think one of the things that you brought up earlier was around the issue around how do we destigmatize
Yeah.
Cannabis?
Right.
How do we destigmatize it from the professional level? Because even providers, the patients may come in
Right.
and request it, and the patients are afraid to request because they think their healthcare providers aren't comfortable.
Right.
So I think there are 2 things,
They're
Dr.
not.
Hinson, because they're not, that is true.
Some of them are not, and they're not educated. I know sometimes there's still physicians that will say you're taking an illicit substance if you say like, do you
Right.
consume cannabis?
Right, right.
Even myself, like I gauge my provider, like, oh, like, do you consume drugs? And I have to be like, what do you define as drugs? And then I have to answer the question, right, in a certain manner, because we prescribe things that people are overdosing from and addicted to on the streets all the time. But I think because within this what Western medicine is and like what we've been taught is okay, we deem these things okay versus something that people have been using culturally for thousands of years that's much safer, that has a lot less side effects than the things that we have pharmaceutically, right? And then even what we learn in school, we are educated, like this is still one big industry. Like we are trained to be employees within this larger pharmaceutical industrial complex. So like what we learn in school is really dictated by the research that pharmaceutical companies do. So like I was lucky enough to go to a pharmacy school where I had a natural medicine elective that I could take, right? It wasn't anything that was going to be on my state exams or my board exams, but at least that was an option where there were professors that understood that stuff or understood those things as an option. So I think again that education piece is key across the board with destigmatizing. And then the other, sorry, the thing from earlier was you were asking about pricing, right? Regulated cannabis is a bit more expensive than what you would get from the legacy market. And I think that those is the differentiation, right? And depending on where you've been going in the legacy market, the safety is the aspect. So what Dr. Hinson was speaking to is if the person that you've been purchasing your cannabis from grows it themselves, you've known them for 25 years, you've been buying the same thing, all right? You grew up together, what have you, that's different than all these smoke shops that aren't licensed by the state that are popping up in these different neighborhoods, right? And again, time back to it is like why education is important. Why is regulated cannabis important? Because the state is telling you that it's safe. They've tested it for mold, pesticides, pathogens, heavy metals. Cannabis is a bioaccumulator. It's going to absorb everything that's in its environment. So if it's an unhealthy environment, now you're consuming an unhealthy product. Whereas if it's coming from a regulated dispensary, you at least have that stamp of approval from your government, knowing that it's been tested, that it's safe, right? And that's the piece of it where what are you willing to pay for, right? Are you willing to pay for that safety or that peace of mind? Right, if you don't know who your provider is, right? And that was a differentiation. Like, there are people who have long-lasting relationships in the legacy market. I would never speak against that. But then there's this new gray area that's popping up where there are folks that are very unethically just providing whatever is available. And again, to bring it back to education again, our younger community, right, that just sees cannabis as legal and available, but because we still don't talk about it, because it's still a negative thing. Like, I grew up being told not to drink, right? Drinking is an adult thing, right? But I was educated on it. So even in high school, when there were kids drinking, I knew not to drink, right? Versus if we still have cannabis in a closet and we're not talking about it, and then kids are around other people who have access to it or they can access it themselves, they don't understand that they shouldn't be consuming it at a very young age. They don't understand that this might be unsafe for me, or wherever this is being purchased from might not be a place where it's safe, right? So again, why the education piece is so important.
Yeah, and with respect to, ways we can destigmatize it, so it has to be a top-down and bottom-up approach, right? So I think what we have is are far more knowledgeable consumers, because access to information is there, but we also need the top down. So it has to come from the legislation. It has to come from the medical education. Perhaps the reason why some providers are uncomfortable speaking about it is because we're not educated on it. We don't learn about the endocannabinoid system in med school. We barely learn about nutrition, and nutrition is pretty much the root of all disease states, at least the ones that we deal with chronically. And so we have to deal with these things from a top down and bottom up approach.
All right. I see that there is a question.
Yes, good afternoon. The question about education sometimes
Can you
gets.
identify yourself first?
I'm Daniel Lowe. I'm a physician and came here to support my fellow doctors. Always looking sharp, spreading the word, so I'm here. But the question about education is always frustrating, because if all of the providers, say the two of you two doctors up there alone spread the word about education. Now we have a mass of patients who are informed about the benefits of using cannabis. They now go to the physicians at their clinics, and the physicians might not be as readily open to accepting what the patients have to say. And there's a couple of reasons for that, because you have some of these old school doctors who, they know what they know. But then you also have the more innovative doctors who are fearful to talk about cannabis, because they might have issues with their administration that says, this is not legal, this is not something that we want to promote, so they might just kind of brush the patient's words aside. So Marinol, which was synthetic THC, back in 1985, it was approved by the FDA. And then in 86, the DEA made it a Schedule 1 to Schedule 2. So then in 1999, the DEA said, hey, this is working. There's no problem with this. Let's make Marinol synthetic THC, same 9-delta THC, the whole, and they made it a Schedule 3. So, when you look at who's needing the education, the FDA, the DEA, even the WHO in 2003 said, let's make Marinol Schedule 4. So that's something that's safe that you can find anywhere, but it's the same exact, it's just synthetic, the 9-delta THC. So who do we need to educate? So if we have our regulatory bodies, the DEA, the WHO, all supporting the use, and then we have the people on the ground in the trenches saying, hey, we've known about the beneficial effects of cannabis, let's teach our patients. Who are the patients? Who are the people that we really need to educate? And so that's just a point there.
I think that speaks to exactly what I was saying. It has to be a top down and bottom up approach. But I think what you're speaking to really is what the real driving force is behind the idea of introducing cannabis into the market space, right? Because they'll approve Marinol, the synthetic, so that you have to go to their company and buy it, but they give you a hard time you growing it yourself, right? Because if you could grow your own medicine, you don't have to buy somebody else's. So now we're talking about something different, right? That's a money ploy, and that's something we may not want to get into, being in this particular space. But you have to know that that's a force that's out there that's working against making natural forms of cannabis accessible to you. But again, the provider, whether old school or new, again, is uncomfortable because we're not educated in med school on it. And again, medical education is driven by the same industry that's producing the synthetic version of it. So perhaps they don't want us to know about this particular system, because again, if we start to understand it and exploit it ourselves, then there'll be no need to rely on them. So a lot of this is a dependency thing, it's a money-driven thing. But as long as we have access, as long as we have these particular programs in place that which allow like the grow, like I'm a big proponent of us growing our own. Why? Because you know what you're putting into it, what you're not putting into it, right? And then again, that spiritual component comes into it also, because we have an intrinsic relationship with plants. So when you talk to your plant and you touch your plant and you love your plant will love you back. And it grows to develop the things that you need. And once we get back to that understanding, back to understanding that we come from the earth, just like the plants come from the earth. And so we should consume from the earth. We don't necessarily need to buy someone else's product, because there's nothing that man can make that comes remotely close to the power of nature, of God, if you believe in God. So.
I would love to ask a related question, and just so
You can identify yourself.
sure. My name is Anisha Gandhi. I use she, her pronouns. I work at the City Health Department and got to also participate in this series earlier in the year as a co-panelist, very much from the bent of advocating for the expansion of cannabis access as social equity, including racial equity, economic justice, et cetera. I appreciate so much everybody has shared pages of notes, but this piece, you acknowledge that, working in a hospital system, working in medical care, traditional medical care felt exploitative. I've heard colleagues, describe healthcare in this country as an industry rather than, as everybody knows, it should be a human right. I'm curious in what you're describing, how we sort of marry these two when we require the FDA for this legitimacy, when we also want to support people growing their own and sort of naturalizing the industry, if you will. And also, how does that relate to the clinical care piece? Because we also know, right, that we by intention and design have a limited number of MDs in this country, right? That's controlled by the AMA, by medical schools, et cetera, that keeps costs higher for a lot of us for care. And you're describing all of this expertise that, clinicians can hold about right modalities and specific strains. Do you envision a future where sort of that is just a kind of a starting point, and that patients then become educated enough that now, as things get legalized, hopefully nationally, that patients can then sort of self-manage? Or do you see that there should always be kind of medical, clinical management of using cannabis? And I appreciate that you've also both acknowledged that it's really this spectrum of use, that it's not medical versus recreational, but rather personal, which can tip toward self-medicating or not, depending on what you call it.
Yeah, no, I appreciate that. I always say, like, the business of healthcare has killed the art of medicine, right? And I think it's done by design in a way, but I do think there will always be a need for the provider, because there will always be a need for the research. I think the research it has to be the basis for how we practice this. Because again, at the end of the day, herbs are for the healing of the nation, right? This is a plant, it's a medicine, it has nutritional value. And I think as such, we have to learn its value. And the only way to learn its value is by way of research. So I do think there will always be a scientific and a need for a provider. I do see a day where people take more ownership over their own health. And I hope we get to that point. Because again, it's not me who heals you. It's going to be you who heals yourself. I'm only a mere guide, you know, so I can see a space where people come to their provider to have the conversation, to say, hey, do you think, you know, this is something that I should try? Do you recommend a starting place? Because at the end of the day, like I said, there are over 700 different known strains. We're not going to know which strain, well, as of yet, we don't know which strain would best suit you. I do see even that becoming more of a science once we begin to broaden the research. But yeah, I do hope that there will be a day, again, where we marry the science and the culture, where patients tend to take more ownership and autonomy over their health rather than depending and relying on someone else telling them what to do, because no one knows your body better than you. So then, you know, who better to tell you than you how to heal it, you know? So I do see a day where that will happen.
I guess my name is Mindy Saldana, and I have a company, Dulcina LLC, and I'm creating a product for women with endometriosis, which is why I asked about the suppository. Last time I was here at this address, I was a caseworker for ACS. And I stopped working there 2016 because of the endometriosis. So it's kind of funny that I ended up back here again to talk about the plant that basically saved my life. I am what's called a seasoned patient. I've had endometriosis for decades, untreated for many years, and I had to advocate for myself because I had surgeries, I had a lot of treatments. So when I go to a doctor and the doctor or the nurse is asking me, do you still take this medication, that medication, that medication? I advocate for myself and I say, oh, and I also take medical cannabis. I don't let them ask, you know, do you do illicit drugs or whatever? I right away with the vitamins, with whatever I say, and I'm also a medical cannabis patient because I believe, this plant saved my life. Yeah. So just wanted to put that out there, advocate for yourself. If you have a condition and you know what your path has been, talk to your doctors. They're there to help you, but it's a relationship. They're not your parent. You have to advocate for yourself.
Yep, that is absolutely the case.
I think this is wonderful, wonderful. I'm from Harlem. We're in Harlem. Where are you physically located? Because who are you? Who are you? Okay. I'm Regina Smith, Harlem Business Alliance. We did a tremendous amount of work in this space trying to make certain that it would be equitable, particularly for Black people who've been the most harmed by this plant in this state. This is my chairman, Walter Edwards. I couldn't have done it without him. So my question is, where are you physically located? Because we need this type of information, we need access. And the culture piece is critically important. We've been talking about that amongst ourselves. We really need to have a place where our folks can go in communities like Harlem, throughout the state, where we can have a real conversation with people that we identify with, who we recognize, who we trust, and who we love.
Regardless of where we are, we'll come to you. So so I actually just moved uptown, so I'm in the Bronx now, but Brooklyn born and raised, but I'm in the Bronx, like 15 minutes from here. But that was a joke, but seriously, if there's ever opportunity for like education, speaking, we've worked together to do like medical card drives before where one of us educates, and then after you get the education, you can talk to a physician and get access to a medical card. So we're willing to support wherever, because again, really big proponents of the education piece. Like sometimes one conversation will shift. Oh yeah, we could definitely do that here. Oh yeah. But sometimes one conversation can shift somebody's perspective and send them down a path that they may have shut themselves out from before. and give them some like positive opportunity and change. So yeah, that's me.
Yeah, so I'll leave my card here, but yeah, if you have a network of people, I mean, we all remember the pyramid schemes, the company that we need to sort of do that, that network marketing, right? You have a network, you have organizations, set up a time, we'll come speak to your people, There's nothing I mean, the basis of Medirootz is we're a telehealth-based practice. So anywhere there's internet, you can find us. And we do in-home care. So we come to you, whether in-home, at your job, that's our model. We're getting away from the brick and mortar model because for the most part, it's been ineffective. All right. So wherever you can organize a group of people, we'll come and talk.
So we have one last question.
Yeah, my name is Malcolm Punter. I lead an organization called Harlem Congregations for Community Improvement. And we're partnering with HBA and other stakeholders on attempting to create a medical marijuana research facility. Both of you doctors, thank you very much for your expertise, all three of you. You emphasize that there's generally not enough representation in clinical trials, behavioral and clinical trials. So that means that there's really non-existence in the medical marijuana field. How do we get to a point where we can use expertise from you guys, partnering with the community organizations and other researchers to get a facility or facilities that will concentrate on trials that promote the health of African-American, Latino, and other people underserved traditionally?
I'll go first. I feel like Dr. Hinson is gonna knock this one out the park. But I would say it's already happening now. Like conversations like this, the education piece. There's people in this room who have influence and power that can then push the next thing. As you're talking about that pyramid scheme, and how do we just have that paradigm shift of, okay, maybe I can put some grant money towards this. Oh wow, the city of New York School of Public Health is doing something. Maybe we can align ourselves with this. I think that's how these things start. And then the folks of us who want to do that research, that want to push these opportunities, would then be able to follow up. But I think it takes like a collective community push and conversations like these that are typically like the first domino to make it happen.
Yeah, no, exactly that. I mean, having these type of conversations. I know money is scarce, but if you make it a priority and pool the money together between respective organizations, then it may not be something major, but small things. What they say is the daily small steps that end up something major and not the one big thing. So let's start pulling out. I think we're the only group of people who don't practice group economics. We have all these church organizations, we have all these individual organizations, but we don't talk to each other. We operate in silos and we all deal with the same problem. And we've been saying the same thing. I can't tell you how many times I've said the same thing. I'm pretty sure you've all said the same thing. At what point does the head of this organization talk to the head of this organization? Listen, this is our budget for this year. This is our budget for this year. This is thing, medical cannabis, that we really want to highlight. Let's both throw some money in the pot. That way it takes the risk off of one entity entirely and makes it a collective effort, But I mean, we have to stop just talking about the problem and actually putting actionable steps together to eliminating them, or at least mitigating the problem. We can't effectively eliminate everything because some things are just conditional. But there are things that we can do on our own to help mitigate these issues.
So I wanted to say thank you so much to Dr. Charles and Dr. Hinson for an engaging, thoughtful conversation. As you can see, we've covered quite a number of things. And I think one of the things that's important in terms of getting medical professionals more knowledgeable, so that way they can at least understand cannabis and then help patients. Because if patients come in, they can at least provide information, getting more engaged in terms of research. I think that's a key thing as well. So that's very important. So thank you both very much for this conversation.
I know y'all can do better than that. Thank you, Dr. Hinson, Dr. Smith, Dr. Charles. Really, I can't tell you if I could jump up and down and act a fool right at this moment, I would, but I'm going to contain myself. I also just want to acknowledge Dr. Punter for his support from HCCI, who has been helping us with this series. We couldn't do this without folks like Regina, who laid the pathway for us to be able to stand in this space to have these conversations. There are some real trailblazers, like say what you want, but there are folks like Anisha who have been helping us think through diversity, equity, and inclusion. If it hadn't been for Charles at CB10 saying, like, we need to bring this to the streets. The goal of the school is really to create these spaces. It's not to tell you what to do. That's really not it. It's not to tell you to use, not use, but if we can't have real conversations that are based on science, then we're doing a disservice to our own communities. So you have now all been dubbed, whether you're in this room or you're online, as a carrier of the right information, of the truth. Again, not telling people what to do, but creating a space where we're able to talk with folks like at Ryan. And thank you, Charles, for coming into the space. Thank you to our medical school for showing up and showing out. Because again, this is how these conversations happen. So when you look around the room, you're not sitting by yourself. You now have a whole cadre of folks who have got this seed, and now we have to be able to turn it out and share it with others. So having said that, there is a closing poll that we'd like for you to take, and you'll see that the screen is there. I'm acknowledging again our partners because they took a risk on us. We're the School of Public Health and Health Policy. People just assume we're going to say no. They're going to assume that we're going to tell you don't do it because. But this is really a space now that, because of our partners, we're able to look at it from an economic standpoint, from a medical standpoint, a recreation, a justice standpoint. People have a right. And I should also just drop this dime right here, is that in Upper Manhattan, we don't have a medical dispensary. One. So just to say that when we talk about access to care, people have a right to make a decision about what they need and how they access. But in order to be able to do that, we also have to have the places that are culturally competent, linguistically sensitive, built by us, for us. So I dropped that there so that as you're talking to other folks, just be mindful that we still have some deserts right here. So really quickly, just to close out, there is a fabulous conference coming up July 11th to the 14th, Black Health Connect Conference 2024 in Washington, D.C. It is hybrid. It is by our very own Dr. Charles. Dr. Hinson will be there. A few of us will be there. But what I will tell you more than anything else, there are like-minded people there that want to move the agenda. And so we've got to be able to support in order to be able to get this word out. I would be remiss if I didn't say this last closing piece, which is please follow us on our social media. It is where you'll find all of the events that are coming up. If you go to our YouTube channel, you will find all of the webinars that we have done. They are all free. They have continuing education credits. You can share them with others. If there are things that you think about that we should be talking about, please reach out to us and let us know. That's what I can say to that. I want to also thank my staff, T in the back. We have Ariacella and Priya. They're the ones who put this event together, sent out the invitations, got you in the room, developed the questions, but most of all are committed to making sure that this space, again, is a safe space. So on that note, I will say thank you and look forward to seeing you soon. We will make sure that when we send out the thank you notices, that we include a glossary of terms so that for folks who may not have gotten all of the cannabinoids and the terpenes and the ratios, you will have a document that gives you that, and it is a growing document. So know that as the terminology changes, we will continue to update that. What did I miss, Priya?
Thing I'd like to add. Thank you all in Zoom land for joining us today and for everyone in person. Again, my name's Priya. I am the project manager for HHI's Public Health Webinar Series. And there's just one more thing we'd like to add. Deborah talked about all of the leaders we have in this room. And she thanked our team, Tamisha, Ariacella, myself, but we'd all like to thank her. Yes, round of applause for Deborah Levine, everyone. Thank you. On May 14th, Deborah was awarded the Staff Leadership Award here at CUNY-SPH. And for those of you that don't know, we're hybrid here, so it's been a little while since we've had the whole team in person, and we've had a crew of people that have worked with Deborah throughout her career with us at CUNY-SPH, the Harlem Health Initiative, and everything else that she's done so far in her career, which is very extensive. It surprises me every time she's like, oh, I know that person. I'm like, ha, you know everyone, Deborah. You worked with everyone. So we just want to show our gratitude to Deborah. We have something very small for her, and since you're all here today, we'd like to celebrate that with you. Deborah is lifting everyone up always and always supporting us, and she has a green thumb, so we got her an orchid. Thank you. Thank you for everything you do.
Thank you.
That's all, folks. Thank you for coming. Thank you for joining on Zoom.